Thank you, Mr. Navneet. Before I start the topic today, I would like to thank Professor Nilima for organizing this topic of endoscopic decrocysterinostomy, a topic which is very close to my heart, and we'll be talking about preoperative workup, surgical technique, and complications. So these are my financial disclosures, book on all the topic that I like, the 3 editions, the latest one on endoscopic DCR, then the whole Springer video portfolio, and the latest one that has come on rhino-orbitocerebral mucormycosis. So coming to the topic, I have added a lot of slides on preoperative evaluation of patients because there are a lot of videos on YouTube that would guide you how to perform the surgery, and all these steps are clear. But preoperative evaluation is one most important aspect which has not been given anywhere, and which actually has a very important role in deciding our outcome. Sometimes we keep blaming ourselves while the case selection may be wrong. And if we talk about preoperative assessment, it is different in adults and children. So let's first see about preoperative assessment in adults. If we history, all of us know that patient may present with watering, with discharge in the medial canthal area here, with pain and redness around the eye with discharge. If we look at the external examination, we might find a medial canthal swelling, like in this case, or there could be a lacrimal fistula, and which sometimes you see only after you syringe and you can see the dye coming out of this fistulous opening. We may have a frank lacrimal abscess and discharging fistula, and we may have scar from previous surgery in failed cases. So the most important test is Ropla's test, that is regurgitation on pressure over the lacrimal sac area. So when the lacrimal sac is full of discharge because of the obstruction lower down in the nasolacrimal duct, so when this medial canthal area is pressed, there is regurgitation of secretions, and it indicates that there is NLD block. This is diagnostic of NLD block because the secretions are infected. That means the secretions have come from the lacrimal sac. So all this proximal system of punctum and canaliculi is patent. So the obstruction is likely to present at the NLD site. The most important part in this is irrigation of lacrimal system, as we know. If we irrigate the lacrimal system, there is regurgitation of turbid fluid through the opposite punctum, as we can see in this diagram. So this is very clear. One, we have Ropla's test. Two, we have regurgitation of purulent secretions in the medial canthal area. What happens if there is regurgitation of clear fluid through the opposite punctum? So we have some videos to explain. As we know that this is the schematic diagram representing the canaliculi. I'll just run this video. So we can see this is the vertical canaliculi, this is the horizontal canaliculi that joins to form the common canaliculus. Similarly, in the upper part, upper canalicular system that joins to form the common canaliculus, which opens into the lacrimal sac. So now, lacrimal sac continues into the nasolacrimal duct. So if we perform syringing through the lower punctum, we can see the passage of fluid marked by these arrows. It goes straight into the nasolacrimal system. If there is NLD obstruction here, then there is collection of secretions into the lacrimal sac, and these secretions flow back through the canalicular system. And since we are pushing the fluid through the lower punctum, they regurgitate through the upper punctum, as we just saw in the diagram. So this is diagnostic of nasolacrimal duct obstruction. There are multiple combinations that can be explained with the help of this video. Suppose we pass clear fluid. We irrigate the system with saline, and clear fluid regurgitates through the upper punctum. So in case there is clear fluid regurgitation, we must consider a possibility of canalicular obstruction, because from here the fluid is going back. the clear fluid is regurgitating through the upper punctum, that means there could be a possibility of common canalicular obstruction, but it can be NLD obstruction also. In that case, when the irrigation is done through this lower punctum, the fluid passes into the lacrimal sac. There is a possibility that the secretions in lacrimal sac are not infected, and there is simple watery fluid which is filled into the sac, and that regurgitates through the upper punctum. So it is not necessary that clear fluid will only be common canalicular obstruction, but a possibility should be considered. So coming to the next slide. It is important to detect canalicular obstruction. So far we saw very clear features, very clear factors which would tell us the site of block. But if we have the canalicular obstruction, then let's look at this video. If the fluid is passed through the lower punctum and it regurgitates through the same punctum, this indicates that there is an isolated canalicular block either at this level or this level. So the fluid does not pass beyond this and it regurgitates through the same punctum. In that situation, it is recommended that irrigation be performed through the upper punctum. So there are three possibilities in that. One is that the fluid passes through the canaliculi into the lacrimal sac and nasolacrimal duct is patent. Patient still had epiphora because this was blocked, but we need to assist through the upper punctum. And if it is patent, then nothing needs to be done. Second situation is that fluid passes through the canalicular system and there is NLD obstruction. And there is collection of secretions into the lacrimal sac. They flow back through the upper punctum again. So in that case, DCR is recommended because there is NLD obstruction and one punctum is patent. So DCR works very well in this situation. So this patient already has lower canalicular block. Just in case we perform irrigation through the upper punctum and the fluid regurgitates through the same punctum again, that means there is upper canalicular obstruction also. In that case, it can be at any level. So the fluid regurgitates. This patient already has a lower canalicular obstruction and he has the upper canalicular obstruction also. Then the management is very different. And we need to do a canaliculoplasty based on the site of obstruction that we'll be talking about. So this flow chart basically I've explained with the help of this flow diagram. And those of you who are interested can go into the fine details of what I've written. I've written exactly what I just told you, that if there is irrigation of lacrimal drainage system, if there is clear fluid through the same punctum, then canalicular block. Repeat syringing through upper punctum. If there is free flow, no intervention. If regurgitation, it indicates NLD obstruction, then we go ahead with endoscopic DCR. And if regurgitation through upper punctum, that means there is canalicular block in the upper system also, and then probing is done. Of course, it may not be possible for all of us to perform canalicular traphinations and all, and it is not possible for me to go into detail of every chapter, every aspect of it, because every aspect has a different chapter. Canalicular block is one chapter and NLD block is another chapter. So I'll be touching up all those things that I feel are important for us. So now let's go to probing. We've done syringing, and if we expect canalicular blocks, we must perform probing. Since probing is an useful adjuvant to syringing for diagnosis of canalicular obstructions, but no larger than 00 probe should be used. There are numbers written on the probe on the back side, and this 00 number, that means a fine probe should be used to avoid injury to the canalicular system. Now, canalicular obstructions can be divided into the proximal, mid, and distal canalicular obstruction. And why do we divide these obstructions? Is because the outcome depends on the site of obstruction from the punctum. So if we go to the previous slide, if we can see here how do we measure the site of canalicular block is that when the probe is passed through one of the punctum and a soft stop is felt at the tip of the probe, then probe is held close to the punctum. It is taken out without disturbing the position and it is placed against a scale that tells us the exact length of the canalicular obstruction. And this is a very efficient method that we've been using routinely. And that is how we know the site of obstruction. So proximal obstruction is one that lies from 2 to 3 millimeter from the punctum. And the mid-canalicular obstruction lies at 3 to 8 millimeter from the punctum. And beyond 8 millimeter is considered as distal canalicular block. So this canalicular block is treated by trephination, and the success of distal canalicular block is highest because we have to only canalize this segment. If there is an obstruction here and if we start from the lower punctum, if we put a trephine, then this segment is likely to be lost, creating a false passage. So this is important from the management point of view. Now it is very essential to know the correct technique of probing, and the same is applicable in syringing also. I have not described in detail about what type of syringing cannulas we can use. There are curved syringing cannulas that are available in the market. We often use the straight cannulas, but you can use anyone that you are comfortable with. The right technique is described in this schematic diagram also. We can see that this is the vertical canaliculi. So once we pass the probe through the punctum, it has to first go vertically. So for vertical insertion of the probe, the lid has to be retracted inferiorly. And then we see the horizontal canaliculi. After this vertical canaliculus, it goes into the straight, this lateral or horizontal canaliculus. So to straighten the horizontal canaliculus, we need to stretch the lid laterally, like in this case. So the cannula goes straight in, or the probe goes straight in into the lacrimal sac. And if we want to measure the site of obstruction, we can measure. This is the hard stop. We often talk about soft stop and hard stop. What is hard stop that indicates that patient definitely has nasolacrimal duct obstruction is that when we pass the probe horizontally using this technique, then it goes and hits the bone covering the medial wall of the lacrimal sac. That means we are already into the lacrimal sac. So we withdraw the probe a little bit and then syringe or measure the size of obstruction if it is any. What is the false obstruction? If the canalicula, if the lid is retracted inferiorly rather than laterally, then there is kinking of this canaliculi and the probe or cannula will go and hit one of the wall of the canaliculi, and this will lead to the false positive result. Now, how do we identify canalicular obstructions? There are multiple ways by which canalicular obstruction can be diagnosed. One, I just mentioned about the kinking of the canaliculi. And second, most important is there is something called CLF, canaliculo-lacrimal sac folds. So once this is a case of endoscopic DCR where the sac has been opened and we can see the probe that has been passed through one of the punctum into the lumen of the lacrimal sac. That's the common canalicular opening, which is very patent. Nice, we can see, but this probe goes and hits into one of the mucosal folds of the lacrimal sac marked by the arrow here. So this gives us a false sense of soft stop. And if we have not opened the sac and we are doing a preoperative evaluation and we feel a soft stop, then we might say that patient has a canalicular obstruction, which is not true. So how do we differentiate it and how do we know that it is not a false canalicular block? I'll be talking about the false canalicular block in this. The false canalicular block can be identified by the fact that regurgitation of turbid fluid in these cases indicates a patent canalicular system that allowed reverse flow of lacrimal secretion. But before that, the preoperative identification of CLF can be made by feeling a soft stop at or beyond 10 millimeter. Why I'm saying this, I'll go back to these slides and I'll show you with the help of this schematic diagram. See, if look at the dimensions of the canaliculi. This is vertical canaliculus, which is 2 millimeter, and this is horizontal canaliculus, which is 5 to 6 millimeter, and this is common canaliculus, which is 3 to 5 millimeter. So if we take lower limit of all the canaliculi, so this becomes 3 plus 6 plus 2, so 11 millimeter. If we take it 5, this becomes almost 10 millimeter. So if we pass a probe through the lower canaliculi and we feel the obstruction at 10 millimeter and measure it the way I just mentioned by holding it close to the punctum. So that means if the probe has already reached this till this level, then that means this whole system is patent. It is very unlikely that patient will have common canalicular block. The probe can go and hit into one of this soft mucosal fold or the wall, which will give us a feeling of false canalicular obstruction. So this is very important. And now let us go to some key points. The key points are that syringing should always be done by self. The operating surgeon should evaluate the patient by herself or himself. It is very, very important because a lot of findings are likely to be missed. Even if the best people have done it, you should do it yourself so that you know where are the exact site of block. Syringing should be done through both the puncta. And why it is important is I just mentioned that if lower canaliculus is blocked, then we perform syringing through the upper punctum. And if the nasolacrimal duct is obstructed, we carry out endoscopic DCR in that situation. But sometimes what happens is the tears are drained through both the canaliculi, both upper and lower canaliculi, we all know. So some patient is likely to have some amount of residual epiphora. He will not bother about the discharge that has disappeared, the swelling that has gone. He will keep complaining that I have some amount of epiphora. And we did get a patient like that, a VIP patient, and when we did probing through the lower punctum, it was blocked. He had canalicular obstruction, and he said, why wasn't I told earlier that you have guarded prognosis and your one canalicular system is blocked and you are likely to have epiphora. So it was really a difficult situation, and I thought I should add this point. And this patient happened to be a doctor's father who was operated outside. Now a lot of eye surgeons are also doing endoscopic DCRs, and this incidentally was operated by an eye surgeon who himself did not do syringing through both the punctum. So if there is clear regurgitation, then probing should be done, as I just mentioned, that in case of clear fluid regurgitation, it can be a common canalicular obstruction also. And a false and true soft stop should be identified, as we just mentioned. False canalicular block may be felt due to CLF. The next point in preoperative assessment is nasal endoscopy. I have not, I have not added a lot of diagrams into it because we as ENT surgeons, we have seen a lot of endoscopic pictures. What is important for us is that the area of nasolacrimal duct system, nasolacrimal system should be examined on the lateral wall. Any compromised access in that area should be noted, which could be due to high posterior deviation of the septum, a pneumatized middle turbinate, a paradoxical middle turbinate, and status of uncinate process, which is very important. It is often hypertrophied in traumatic cases, and it tends to encroach the maxillary line, which is the landmark for finding the lacrimal sac. We should also note the synechia from previous surgery and should not be taken for surprise on the table. And the last point in the investigation is imaging. We know CT decrocystography is the investigation of choice. It is not done routinely in all the cases, though it is better from research point of view if we do it, because a lot of times we've seen interesting findings on the table and we said we wish we had the CT scan. So we do it in most of the cases unless patient is very poor, old, or cannot really go. So what CT-DCG shows us is this dilated lacrimal sac. This is opacified with the contrast, and we can see the nasolacrimal duct, which is obstructed here. There is no flow of dye into the nasolacrimal duct, while the sac on the other side is normal size, and we can see the canalicular opacification. So there is a lot that we can study on CT-DCG. I have not added into this particular presentation, but the amount of difficulty that we are going to encounter during surgery can be easily picked up by endoscopic DCR, by the CT-DCG. And in all revision cases, we definitely send the patient for your CT-DCG. Why? Because look at this. This is the lacrimal sac, and there is another opacified shadow. This is called lacrimal diverticulum. Diverticula is a thin pouch of the lacrimal sac, which is often seen in cases of dacryocystocele because the lacrimal sac expands and its wall is thin, and generally in the inferior medial quadrant, the wall is weakest and there is space, so it extends, and this is how it is seen. So if we just open the lacrimal sac and we see the probe through the lacrimal sac and do not really discover this diverticula, then there are chances of failure, and we have seen cases like that. So this is a very interesting finding on CT-DCG. And then again, this is not just the cystic dilatation of the lacrimal sac. We can see the thickened uncinate process, which actually looked like middle turbinate during surgery. So this patient suddenly came to us. We kept it for one of the course and had not done the nasal endoscopy. And we just did CT-DCG and found on the table that he had very thick uncinate process. So CT-DCG is very effective, especially in post-traumatic cases. We routinely do in all the post-traumatic cases. Now, coming up to the preoperative workup for DCR in children, as we all know that children will not allow probing and syringing. So how do we diagnose obstruction in them? We need a definite protocol for preoperative evaluation in children because of many reasons. If a child comes to us with this kind of presentation with matting of eyelashes, excoriation of the skin, and edema around the eyelashes with thick purulent discharge, the diagnosis is clear. Whether we will do probing and syringing or DCR in this case, we'll be talking about in further slides, but this is the clinical presentation. And the examination is done by fluorescent dye disappearance test. Fluorescent strip is used and saline drops are instilled into the eye, into the medial canthal area. A cotton tape applicator is inserted into the nose of the child, and if we see the cotton tape is sustained, that means this child has a patent nasolacrimal duct obstruction. We don't really need to perform DCR and find the other causes of epiphora. While in this child, we can see that the dye is retained into the eye, and it indicates obstructed lacrimal drainage system. Now, how do we approach to a child referred for endoscopic DCR? If a child comes with thick purulent discharge, we do not go straightway for endoscopic DCR. There is a process. We look for the discharge or watering. If there is discharge, whether it is Rho plus positive, or if it is Rho plus positive, then we ask for history of intervention. If there is history of intervention, was it a conventional or blind probing? Because generally treatment of choice in congenital nasolacrimal duct obstruction is probing, and it is a blind probing done by most of the surgeons across the globe. Or the patient might have history of endoscopic probing and still have epiphora. So it is important for us to know why. Because if there is conventional probing history, then we plan endoscopic probing. And if there is no intervention, then also we plan endoscopic probing. If patient is already undergone endoscopic assisted probing, then we examine the inferior meatus. There can be unfavorable situation or favorable situation. What is an unfavorable situation? The mucosa is tightly draped over the valve of Hessner into the inferior meatus, and the probe cannot be seen into the inferior meatus. There is minimal mucosal movement seen. I wish I could show all the photographs, but then this would have become a very long talk. We have all the photographs related to the things that I'm talking about. There could be occasional dacryolith in the inferior meatus, so we need to widen the incision with the sickle knife. In these three situations, we perform endoscopic DCR. In dacryolith, we do dacroendoscopy using a CLO endoscope that we pass through the punctum and see if we can see the dacryolith and it is blocked. Then either we do endoscopic DCR or we can do then-assisted recanalization in this case. Favorable situation is a bulging membrane over the valve of Hessner, and we do endoscopic guided probing and check patency. If there is watering, we do FDDT, as I just mentioned. If it is patent, then nothing needs to be done. It could be functional epiphora, nasal allergies, or some edema of the mucosa. If it is obstructed, we have to find out whether it is NLD obstruction or punctal atresia, which is not uncommon in children. We find in quite a few cases. So if NLD is obstructed, then we go ahead with inferior meatal endoscopy and follow all these steps. Punctal atresia, of course, I don't have to go into the details. There is a management for that also. Now coming to the surgical technique of endoscopic DCR, landmarks are the most important thing. This is the left nasal cavity endoscopic picture showing middle turbinate, septum, axilla of the middle turbinate, frontal process of maxilla, and we can see the uncinate process. So this maxillary line is the junction of the uncinate process with the frontal process of maxilla. And we know that the sac extends around 8 to 10 millimeter above the axilla of the middle turbinate. So that is the site of incision. If our incision starts from here, there are high chances that DCR will fail because this portion remains unexposed. So going to the surgical technique, this is a short clip of endoscopic DCR of the left nasal cavity. That's the uncinate process. That's the lateral wall, and an incision is given using a 15 number blade. Mucoperiosteal flap is lifted. This is thin lacrimal bone. See how such a favorable case that you can easily find out on the CT DCG. So that's the lacrimal bone that you can see me palpating with the suction dissector, and that's the frontal process of maxilla. And fortunately, in this case, even the frontal process of maxilla is thin. So we don't have to go till the uncinate process. We just stay here and start removing bone from here. A standard Kerrison punch is used to nibble out the bone. We start seeing the lacrimal sac as soon as the bone is removed. If we are lucky, the whole bone can be removed using Kerrison punch, but believe me, it's very rare. It's not very common. We can see the whole lacrimal sac so nicely exposed. And this was an old lady. I would say the easiest case that I've taken to show you. I'll also be showing one little difficult, not the very difficult ones, though we have a lot of variety. Look at the common canaliculus. It's beautifully exposed sac with so much of portion above the common canaliculus, which is a key factor. And I'll be talking about it, why I'm saying this. Because this is a schematic diagram of the same patient exactly that I just showed you. That's the probe through the common canaliculus. And this is the 360-degree mucosalization of the ostium that we have created. This is the anterior lacrimal sac flap. This is posterior lacrimal sac flap. That's the mucosal flap. One part goes up and the other comes down and goes along the lateral wall, and that's the middle turbinate. So how high should be superior osteotomy means how much you should drill above the common canaliculus to have a successful surgery. So the questions are how much to drill, what landmarks do we see, is against eye visualization sufficient to ensure complete bone removal has been done, ability to incise the sac and visualize the probe in the nose is enough? No. Why? Because probing is the only thing which is most useful guide. And one must be able to tilt the probe up superiorly and ensure that it does not hit the bone. So this is around 3 to 3.5 centimeter area, a millimeter area of the sac, which must be exposed around the common canaliculi. And as per this study, they have measured, and even we have measured. If we just see the probe, which is abutting along the superior surface, along the bone superiorly, then the DCR is likely to fail. And complete mucosal coverage that I just described. It's a beautifully covered sac. And if we go back, we can see that in this case, we had seen this probe through the common canaliculus in exactly the same row. Now let us see DCR in a maxillary bone dominant fossa. What is maxillary bone dominant fossa? It is a situation in which the lacrimal bone is almost missing. the whole fossa is formed by the frontal process of maxilla. So it's a very thick bone. We do not find place to engage our bone punch. If we are very careful in watching our CT DCG prior to surgery, sometimes we are able to detect this thickness because we did it in retrospect. We went back and saw the CT of this patient and found the difference from this patient and the previous patient. I wish I had kept the CT. I did not. Let's just look at this video. That's the, see, the Garrison punch cannot be engaged. There is no ledge of bone or no lacrimal bone where we can engage our Garrison punch. So these cases need to be drilled right from the beginning. Of course, flap should be lifted to make sure that there is no lacrimal bone. If it is there, then we are lucky and it gives us a point to engage our Garrison punch. So if we know preoperatively, then we are prepared that we will have to drill the complete bone. It is better to take a new burr in these situations and keep drilling and focus more on the superior part, because in cases where the bone is thin, sometimes a lot of energy goes in drilling the inferior part, and by the time we reach superiorly, we are tired and we end up doing an incomplete job. The duration of DCR varies from, surgery varies from 15 minutes to 3 hours, depending on what is the situation that we are facing. So in this case, it's of course an edited video. We can see the whole lacrimal sac has been exposed. That's the flap. So the sac is incised. We can use anything. We can use a crescent knife. We can use this cataract knife. We can use a 12 number blade. Depends on what is convenient to us. So the sac is incised and we can see the mucopurulent secretions flowing out into the nose, and that's a beautiful canalicular opening. We can see the probe, and a substantial portion of the sac has been exposed above the common canaliculus opening, which tells us on the table that it is going to be a successful case. So what are the causes of failure in endoscopic DCR? Most important, improper case selection, inadequate bone removal, inability to see the sac superior to the common canalicular opening, synechia formation, deviated septum leading to synechia, and ostial cicatrization. So let's have a look at this failed case of DCR. She's a 50-year-old lady who presented with the history of external DCR done twice, history of endoscopic DCR done once, history of fistulectomy was done once, and she had persistent epipora. The conjunctiva was muddy, and there was congestion and edema in the medial canthal region, and she was in a lot of pain. So when we did her endoscopic DCR, this is not a very good video, but I kept it and I'm showing it because it's a nice case. And in this case, we can see this is the left nasal cavity. There is a synechia there. There's a gross septal deviation. A lot of things that we do not correct during surgery. We can see a lot of edema and granulations. An incision is given exactly in the same way as we give in the primary DCR. And see, we can see so much of bone has been exposed. If we see, this is the part of the sac that we see under the bone, from where the bone has been exposed, and the rest of it is under the bone. So this is the demarcation. This is all bone covering the major part of the sac, and only from the lower part or the NLD part, the bone has been removed. So what we did was that we palpated this portion. Look at the middle turbinate. There is so much of edema, and we drilled this superior bone. Oh, sorry. There are multiple reasons why this bone is not drilled, and I would say the lack of equipment, the confidence to drill into the nose, and also sometimes we feel that the superior limit has reached. So inability to reach the superior limit is another reason why the fundus of the sac in the superior portion is left behind. And often in long-standing cases, it is the superior part of the fundus of the sac which is filled with granulations. So if there are granulations in that part and that part, superior part, has not been marsupialized, then there are very high chances that the DCR will fail. This is a very old video, but this is an example of how many attempts were done on this particular patient. And he was a poor gardener who was referred from outside, and she was crying and he was crying, saying that do something, hopefully you can do something, everybody has tried. But of course this is an old case, some 5-7 years ago. Now a lot of people do good DCR surgery, but I showed it so that everyone knows that this superior part needs to be exposed. And if there is no remnant of the sac is left which has not been exposed, then the outcomes are excellent. See, inside the sac also, inside the lumen, it is so thick. We debride all the extra part, and I'll not be showing that video again because then it hangs. So what we do in these cases is that we inject mitomycin C. We also put a swab of mitomycin C so that the fibroblast formation is less, and this is what is all recommended in revision DCR. So these patients are likely to do well in post-operative period. Now coming to the complications of endoscopic DCR, there can be subcutaneous hemorrhage. Like we see in these cases, this means the periorbita has been breached somewhere, and this patient has even redness of the eye. There could be granulations, very common, and that is why check endoscopy is repeatedly recommended, and that is how stenting also helps. This is of course a failed case with polyps and adhesions, and these are granulomas which can be very well handled during post-op period and can salvage your DCR ostia. Then there are synechias at multiple levels, as we see in this. If we know preoperatively, then we plan better and we keep more time for our surgery. Then tube prolapse, of course, it can prolapse through the external. If you see, this is an external DCR that has been performed with stent. So then they send to us to check through the nose and either we repose it or remove. And then cheese wiring. This is after stenting. The puncta, and there is slitting of the puncta. This is called cheese wiring of the puncta. That means the stent which was put here was too tight. So that is why when we put the stent, we try to check the medial canthal area by placing an instrument below the loop and make sure that it is not very tight. Then fat prolapse. It is again an indication, again a complication that if I tell you how it happens, probably you can avoid it. If you see this case, this is a revision case. We did a lot of drilling, and that is why after that we can see this fibrotic flap. You can see the anterior lacrimal sac flap, posterior lacrimal sac flap, and these warty growth filling the lacrimal sac lumen. If we find anything like that during revision surgery, we make sure that we send it for histopathology. So in that attempt, what happens is if I can show you my hands, if this sac is like this, if we have opened it like this, so through this mid center portion, if we are clear about the anatomy of lacrimal sac, how it lies into the inferior-medial quadrant of the skull, and beyond this is all lamina peperacea. So if we go into the junction, into the depth to take biopsy or take out tissue, then we might pull a little bit of fat. So that's how the fat prolapse, and we should recognize it immediately on the table. Nothing needs to be done. There is no problem if it happens. At the most, patient will have a little bit of bluish discoloration of the skin around, if at all. But that also did not happen. So you just leave it here and go ahead with your own work. CSF leak following endoscopic DCR is extremely rare, I would say, because fortunately none so far with us. 2 patients reported from outside, and that too all telephonically managed conservatively. That's what I was told, that Dimox was given and they became all right. One was post-traumatic DCR done by an ophthalmologist. In fact, both were done by ophthalmologist. They were doing endoscopic DCR in post-traumatic case, and there are multiple causes. I will not go into the details of why it can happen. In post-traumatic cases, the The cause is that we try to use a Killian speculum to recline the nasal septum. As ENTs, we have low threshold of doing septoplasty, and we go ahead with a septal correction as soon as we see this, because we know in post-operative period also patient is going to have adhesions. So if adhesions are there, then DCR is likely to fail. So we do not leave any deviated septum if it is grossly deviated. But if surgeon tries to use a Killian speculum, as sometimes you are also told that you open it tight so that the septum goes to the other side. So the use of Killian wall speculum to recline the nasal septum rather than doing a septoplasty was probably the main cause of anterior skull base fracture as reported in literature. And cranial insertion of the perpendicular plate of the ethmoid directly into the cribriform plate is responsible for an ethmoidal breach, and that may occur due to forced reclining. I will just go back and bring this up if I can. Okay, this was the reference that I used for this. You can all read that article, but it's not coming anyway. So that's all for today. If you have any points that you want me to go back, then I can do that. Otherwise, we can take questions now. Dr. Nilima?
Dr. Nishi, thank you. So you may open the chat box and get released. You may type your questions, comments in the chat box.
Okay, so how to use mitomycin and external dacryocysterinostomy is done in much cases. Stenting is done. Okay, so I'll go from the last question first. Stenting is done for which cases? Dr. Kanaka. So I do stenting in almost all the cases, except in children, because for removal of stent, we need to give general anesthesia. Ideally, I should do it in children also, but I do in select cases in children. But in adult, essentially, I put stent in all my cases. Okay, so somebody wants to see first 5 slides. Okay, so I'll just go. This is introduction, and then this is preoperative assessment.
You have to share the screen again, Nishi.
Okay, sorry.
So first, you can just continue with the questions, and then you can at
Okay,
the end.
okay. Yeah, later maybe. Okay, fine, fine. I didn't know I'd stopped sharing. Okay. So if stenting is done, we remove it after 4 weeks. There are enough studies now to give us the evidence that 4 weeks is enough. So essentially, I remove after 4 weeks. Sometimes the advantage of stent is that when we do check endoscopy, if we see granulations, synechia, or we feel that the ostia is not behaving the way we wanted it, so we can leave it for 2 more weeks. What I do is I call the patient and then check every week to see. Sometimes you need to handle the granulations by applying either the TCA or silver nitrate. So in that case, I prefer to keep the stent. Otherwise, it is 4 weeks. Endoscopic DCR from Dr. Faiz Ahmed, whether it is done under local or GA. Endoscopic DCR, I always do under general anesthesia. In the beginning, I did few cases of endoscopic DCR under local anesthesia. If the patient is lean, thin, old, with very thin bones, say 60, 65 years, then it is possible to perform DCR under local anesthesia. But it is difficult to anticipate which patient is going to behave which way and what is the thickness of the bone. And also there is a lot of irrigation and bleeding that goes down the throat, and patient is very uncomfortable. And if you have to drill the frontal process of maxilla, if we want to do a meticulous job, I think it is better that we do it under general anesthesia. Okay, Dr. Dagash Sonpal to all the panelists. Madam, I have seen at my place external DCR is more successful than external DCR. Is it relevant? No, not really, because I think the time has changed. It has been almost 25 years now. I have been giving talk on this topic, and there is a lot of improvement. Why people say this is depends on which area they work, and if endoscopic surgeons have or learning, there is a steep learning curve, because as ENTs we do not get cases, and we might feel that, and whoever is doing in the learning phase may not have all the equipments. We need a lot of equipments, we need drills, we need irrigation, we need micro debrider to give 100% results. And believe me, the results are 99.9%. I work in an eye hospital and I get a lot of referrals from external DCR people also, and we revise them endoscopically. So it is not like that. It is almost obsolete now. If you have the facility, then there is nothing like endoscopic DCR. Failure is more for external DCR. No, this is not done. Okay, so some syndrome in endoscopic DCR, how to prevent it? From Dr. Vijaya Krishna. So Dr. Vijaya, the answer is again same, that complete marsupialization of the lacrimal sac should be done. And for others, some syndrome is a situation in which the remnant of the sac, maybe the inferior part of the sac is left, or some part of the sac is left not non-marsupialized. And if we press over that sac, then there is regurgitation of the discharge. So the answer is that we do complete marsupialization of the sac from the fundus till the NLD, and the some syndrome will not happen. The other question is, okay, very interesting question. Continue watering of the eye is there, but when NLD is done, duct is patent. What to do next? So I don't know who's this question from, and I do not know what is the age of the child. If age of the patient, if it is a child, I mentioned it could be functional epiphora, allergic rhinitis, etc. But in adults also, I would again say that preoperative evaluation is very, very important. There is continuous watering. It could be because of the, it could be functional epiphora, which occurs due to the failure of the lacrimal pump. So I think this can be better discussed one-to-one. And if I knew more about the age of the patient, then the answer would be different. Okay, so I'll take more questions. Can we get a copy of this presentation that Mr. Navneet will
We
answer
encourage
this?
trainees to participate in live lectures and ask questions.
Okay, so you found the answer, and the next question is, sorry, next question, where is the chat? How to use mitomycin C? So mitomycin C comes into a vial that is diluted by adding 10 ml of distilled water into it, and 0.2 ml solution which is soaked. You can use either the Merosil, which eye surgeons use, or just take a small pack and put it inside the lacrimal sac around the ostia, so that it covers the area all around the ostia, the mucosal flaps, and also the lumen of the lacrimal sac. And injection, the circumostial injection of mitomycin C is done only in cases of failure where there is a lot of fibrosis. So that is also done all around the ostia, at the axilla of the middle turbinate, on the mucosal flap, and both anterior, posterior, and over the mucosa. So we'll see if there are more questions. Is DCR indicated during active infection? Yes, I would say something like lacrimal abscess. That is an indication of emergency dacrocystal rhinostomy, because what we do in lacrimal abscess is that we give an incision here over the eye and incise and drain the whole abscess. In endoscopic DCR, we drain the same abscess through the nose. So we pass an endoscope and we open the lacrimal sac. As soon as we open the sac, the swelling collapses in the medial canthal area. So patient is saved of two procedures. If we give an incision outside, which most of the eye surgeons performing external DCR do it, the way they give incision. So what happens is that the skin is unhealthy, and for performing external DCR, they again wait for 3 weeks or 2 weeks till the skin heals. And I have seen in my setup that by the time patient comes, there is again an abscess. So sometimes they send to us saying that the abscess has been drained 3 times, and there is no normal period during which we can perform external DCR. So it is better that we do it in the acute phase. However, if there is just the erythema, a lot of inflammation of the canaliculi, then we can wait. Because in that case, canalicular stenosis, failure, I don't know whether people are using stents or not. So in that case, if there is just inflammation involving the canaliculi, then we can wait for 3-4 days with antibiotic and then go ahead with the DCR. How long you keep mitomycin C in the sac area? 2 minutes, Dr. Yuvraj. And the next question is from Dr. Mahesh Bala. Merocell pack remove how many days after operation? I do not place Merocell pack, not even in FES, because I have realized that it sticks to the mucosa and it is extremely painful for the patient. I know a lot of people use it and a lot of good surgeons use it. We also used it in preoperative earlier days, and I only realized that if we take 1 hour and keep putting saline and keep dragging the packs, if I am the patient, I wouldn't like it. So what I do now is I secure the flaps with the help of gel foam and put that soframycin or the sofratoli packs, and I remove it after 3 days and ask the patient not to blow or disturb the nose for 7 days, and after that we start washes. Okay, this question also from Dr. Ramindra, you can reply, Mr. Navneet.
Now we can go to the slides. There's
Okay.
one more question from Dr. Yuvraj. Just let me share this. Yes.
Okay. Is patient okay? Nasal wash. Yes, we start nasal wash after 7 days. It is better, but you can give nose drops, and when we are doing check endoscopy at that time, also we assess. But as a routine, we give them after 7 days. But I would again say that the role of check endoscopy is very, very important. If you really want to have good success rate, then 1 week, 2 week, 3 weeks, depending on where the patient comes from, is very important. What precaution to take that recurrence will not occur? So this is assuming that we've done a meticulous surgery, and the additional precaution that we need intraoperatively is that I have done myself sometimes that, sometimes you're lazy or you're tired and you don't do septal correction, or you don't do conchal correction. The concha bullosa and septal correction is a must in endoscopic DCR. There are a lot of adhesions formation, and then when you revise your case, then you do conchoplasty, also septoplasty. So one, I would say that correct all associated nasal conditions, and two, take very good care of uh, patient in the post-operative period. And three, I would say that there's no harm using these stents. That keeps your ostia patent, no matter whether there are granulations or syncytials. You will never have recurrence. Is patient need any eye drop antibiotic, Dr. Yuvraj? Question from him. During hospital stay, we give IV antibiotics, and on discharge, we give oral antibiotics. No, not needed. We do not need an IV antibiotics at all. Our standard protocol is to give moxiclav or whatever amoxiclavulinic acid combination for 5 days maximum. That is also because we remove packs. We keep packs so to avoid secondary infection, and we do not keep patient in the hospital. We have a daycare center. Everybody goes home before we come home. So that's all. And eye drops, yes, I use Tobra F, which is tobramycin plus fluorometholone, which is a mild steroid combination, because we've handled the canaliculi and puncta. So even with the stent or without the stent, patient keeps using tobramycin and fluorometholone eye drops, 2 drops BD for 7 days and 1 drop BD for another 7 days. So for 15 days, patient uses this treatment. There is another question from Dr. Kanak Kumar. Repeat the anatomy landmarks endoscopic DCR. Okay. Mr. Navneet, should I go back to the slides?
Yes, now you can start sharing the screen and show the first 5 slides and then anatomy as well.
Okay, okay. Where is my screen gone?
I'm able to see your screen, just open the presentation.
Okay.
Minimize the Google page or just open the presentation, yes. Excellent, slideshow.
Okay, so you can tell me which one to show. This is history, of course. Watering, nobody is interested. They all know what needs to be done. And so these are just the symptoms. I don't know if they want me to do this. 5 slides. This was about the, I will just show the video, a quick video. So this is vertical canalicula, this is horizontal canaliculus. Similarly, in the lower part, this joins to form the common canaliculus, which open into the lacrimal sac. So we see the dimensions. This is 2 millimeter vertical canaliculus, this is 6 millimeter, and this is 3.5 millimeter. This continues into nasolacrimal duct, the sac. So if we irrigate through the lower punctum, it goes into the ampulla and into the sac. If there is nasolacrimal duct obstruction here, there is collection of fluid into the lacrimal sac. So this fluid regurgitates through the upper punctum. Since we are pushing saline through the lower one, so it goes through the upper one and it comes back into the medial canthal area. It indicates nasolacrimal duct obstruction. So if there is purulent discharge, regurgitation, then it is clear that it is a nasolacrimal duct obstruction. But what happens if there is clear fluid that regurgitates through the upper punctum? There are 2 possibilities. One is that there is common canalicular obstruction here at this level, and the fluid will go through the canalicular system, will be obstructed here and will regurgitate. So it's a clear fluid that we are regurgitating and we are irrigating with. And we must keep the possibility of common canalicular obstruction. However, there is another situation in which there is NLD obstruction and the fluid, when irrigated through one of the punctum, it goes into the canaliculi and the lacrimal sac. There is a possibility that there is clear fluid that is accumulated into the lacrimal sac and there is no secondary infection. So this clear fluid regurgitates through the upper canaliculi. So that means there can be NLD obstruction also with clear fluid regurgitation. But this possibility of canalicular obstruction should be kept in mind, which we can detect with the help of probing. So in probing, I'll again show this short video. Sorry. So in this, we can see that as my pen is moving, you can see this regurgitates from this side because there is canalicular obstruction. So if it comes back through the same punctum, that means there is isolated canalicular obstruction and the fluid comes back at any level, either at this level or at this level. So what we recommend in that situation is that you perform probing through the syringing through upper punctum. There are 3 possibilities. One, if the fluid is irrigated through the upper punctum, then it comes through the sac into the NLD and NLD is patent. Patient was having epiphora because the lower canalicular system was blocked. So in this case, we do not need to do anything. No surgery is recommended. The second situation is that the fluid goes through the canaliculi into the lacrimal sac and there is NLD obstruction. So the fluid comes back and the endoscopic DCR is recommended in this particular situation, and the patient will do very well with endoscopic DCR because there is NLD obstruction. Then there is a third possibility. This patient already had lower canalicular obstruction, as we mentioned, either at this side or that side. What if he happens to have the upper canalicular obstruction also? In that situation, when we perform irrigation through the upper punctum, then this will come back through the same punctum, indicating an obstruction in the upper canaliculus also. So now patient already had lower canalicular obstruction. He has upper canalicular obstruction also. We then need to measure the site of canalicular obstruction so that we can decide the management plan. So this is how we measure the canalicular obstruction. We just hold it at the close to the punctum when we feel soft block at the tip and measure it against the scale. And that is how we decide the proximal, mid, and distal canalicular obstruction at 2 to 3 mm, 3 to 8 mm, or 8 mm. This is the correct technique of probing, and as I described in detail, that since this is vertical canaliculi, first you retract the lid inferiorly, then you retract it laterally so that you straighten the horizontal canaliculus, and then you go and feel the hard stop. This indicates NLD obstruction, and this system is patent. Then there can be false canalicular obstruction because of the skinking of canaliculi, as well as with this canaliculo-lacrimal sac fold. And how do we detect the false canalicular block is that it is found at or beyond 10 millimeter. As we just mentioned the dimensions of this. This comes to around 10 millimeter here. So if it is at 10 millimeter or beyond, that means it is hitting one of the wall of the sac and it is not a true canalicular block. And also on irrigation, we will find regurgitation of turbid secretion. That means fluid from here is reaching the lacrimal sac and is coming out here. And what we are feeling at the top tip is not the true block, but it is a false block. So these are the key points. I think everybody knows syringing by self should be done through both puncta. Probing should be done in clear regurgitation. And nasal endoscopy again is very important. This was imaging CT decrocystography, a plain dilated sac and a lacrimal sac diverticula, as we can see here. Please tell me where to stop. Acha, okay, I have to show that landmark for DCR. Sorry, this is the surgical landmark for endoscopic DCR. This is left nasal cavity. This is the middle turbinate. That's the uncinate process, and this is the frontal process of maxilla. We all know that this is called axilla of middle turbinate, and this is the maxillary line, which lies at the junction of uncinate process with the frontal process of maxilla. So the initial concept was that the incision was given here starting from the axilla of middle turbinate, and we often had failure, but now it is well established by the various articles, and one of them is a landmark article by Dr. P.J. Wormald, and now everybody follows this, that the fundus of the sac lies 8 to 10 millimeter above the axilla of middle turbinate. So our initial incision has to be right. If we give an incision here and then we want to expose the sac under the flaps, then sometimes we may be able to do it, but it is cumbersome. So it is better to give the first incision right. If we give incision at this side, that's the horizontal incision. This continues into the vertical incision, which turns into another horizontal incision just above the superior attachment of the inferior turbinate. The advantage is from the fundus of the sac till NLD, we can see the complete sac and NLD. No sump syndrome if we expose this portion also. No failure if we marsupialize this part also. If there's anything else people want to watch, because you can let me know. I think this I have shown. Is there anything else, Mr. Navneet? If this is another good thing, a good marsupialization of the lacrimal sac flaps. That's the superior part of the mucosal flap. This is the inferior part, and that's the lumen of the lacrimal sac, the anterior lacrimal sac flap and the posterior lacrimal sac flap. Exactly the way I had shown in that video. You want me to show anything else? Dr. Nilima?
Dr. Nishi,
Hanji,
excellent presentation.
thank you.
Thank you very much for the presentation, and thank you very much, trainees, for joining us.
I think there is a question. Are we finishing?
Yeah, we can take this last question, yes.
Yeah, contraindications for endoscopic DCR. There is no contraindication for endoscopic DCR with the techniques have been revolutionized altogether. And you all know that we can do complete median maxillectomy from inside the nose. So we can also remove the bony nasolacrimal duct. And even in carcinoma of the lacrimal sac, we've done complete removal by endoscopic approach. Frontal process of maxilla is cut or drilled. We always drill, but if you want to use chisel and hammer, and if you want to do it fast or the drill is not available, then one can carefully chisel and chisel out the bone also. I think that's the last question.
Thank you, ma'am. And
Thank
thank
you.
you very much, trainees, for joining us.